Welcome back to the Deep Dive. We're here to take a stack of sources, articles, research, clinical notes, and really pull out the core knowledge you need with zero fluff.
Exactly.
And today, we are tackling a piece of medical equipment that, I think most people would recognize on sight. But the mechanics behind it, the life-saving intensive care, it's often totally unseen. We're talking about the tracheostomy, or TRAC.
Right, and our source material for this is a really comprehensive, very detailed clinical presentation. It's focused intensely on the mechanics, the maintenance, and the very high-stakes risks that come with TRACs.
So what's our mission today?
I think our mission is to synthesize all these complex clinical facts. I mean, everything from the component parts of the tube itself to the tiny details of daily care, so we can all really understand the level of precision and, frankly, dedication that's required in critical airway management.
That's a great way to put it. It's not just a device.
No, it's a look at the razor-thin margin between a patient being stable and, well, a catastrophe.
That is the perfect framing. When we talk about life support, the TRAC is this silent workhorse, but its function is completely dependent on these meticulous routines. So let's just jump straight into the why.
Okay.
What are the primary scenarios? Why does a patient get to the point where they need a surgical opening in their neck right into their trachea?
Well, the clinical reasons are all driven by one thing, securing a long-term functional airway. And they really fall into about 5 key areas.
Okay.
The first one is, the most straightforward, bypassing an upper airway obstruction.
So like a physical blockage.
Exactly. Imagine something like trauma, a tumor, maybe severe swelling. It's physically blocking the normal path for air high up in the throat. The TRAC just creates a new, clear route below that blockage.
A detour. A physical detour around an obstacle. Okay, what's reason number 2?
That would be the need to allow for the removal of tracheobronchial secretions. So if a patient is too weak or paralyzed or for whatever reason can't cough effectively, mucus and other stuff just builds up really fast.
And that buildup can be fatal.
Oh, very quickly. A TRAC gives you direct access for suctioning, for clearing that airway out.
That makes perfect sense. And I imagine these two issues are often connected to the third big one, which is long-term mechanical ventilation.
They are.
But why is a TRAC better for that than just a standard breathing tube, an endotracheal tube, or ETT?
That's a really crucial distinction. ETTs, the tubes that go through the mouth, are designed for short-term use. If a patient needs a ventilator for more than, say, 2 or 3 weeks, the constant pressure and friction of that tube going through the vocal cords and the larynx can cause some really significant long-term damage. And it's very uncomfortable.
So the TRAC bypasses all that.
It bypasses the entire upper airway. It makes long-term ventilator support safer and, honestly, much more tolerable for the patient. It's about mitigating the damage from the tube itself.
Right, not just from the illness. Okay, so what are the last 2 indications?
They're often related. One is preventing aspiration, so preventing oral or gastric secretions from getting into the lungs. This is a huge risk in unconscious or paralyzed patients.
Because their normal reflexes are gone.
Their protective reflexes are gone. The cuffed TRAC can seal the trachea, preventing that. And the 5th reason is simply replacing an existing ETT when everyone agrees that long-term access is going to be necessary.
Okay, so we've got the why. Now the equipment itself. Looking at the illustrations in our source material, this is not just some simple plastic tube. It's a whole system.
It's precision engineering, really.
Yeah.
The main parts you see are the outer cannula, that's the main body that stays in the trachea, and then there's an inner cannula, which sits right inside the outer one.
And that's the part that gets cleaned.
That's the part that's removed and cleaned regularly, yeah. Because it's what collects all the secretions. It's sort of the sacrificial piece designed for maintenance.
Okay, but how do you get the whole thing in, or, more importantly, back in if it comes out?
Right. For insertion, or in that critical emergency, if the whole TRAC comes out, you use the obturator.
The obturator.
Think of it like a blunt, rounded guide. You slide it into the outer cannula, and it makes the end smooth so it can be guided into the opening, the stoma, without snagging or damaging tissue. Once the tube's in, the obturator comes right out.
And this is where the high-stakes safety protocols really come into play, tied right to that piece of hardware.
It's a foundational, absolutely non-negotiable safety measure. The source is very emphatic about this. At the patient's bedside, you must always have the obturator, a hemostat, which is a clamping tool, and a brand new TRAC tube of the same size.
Always.
Always. Because if that TRAC comes out, the airway is compromised and the clock is ticking. You have seconds, not minutes, to fix it. That equipment has to be right there.
The need for that immediate access really just speaks volumes about the constant risk. So let's talk types. Because it's not a one-size-fits-all situation. The source outlines three: non-cuffed, cuffed, and fenestrated.
And the choice depends entirely on the patient's need for ventilation and their ability to swallow and speak.
Okay, let's start with non-cuffed.
Non-cuffed tubes, some can even be made of metal, are for when you don't need positive pressure ventilation. Since there's no balloon, no cuff sealing the airway, air can move around the tube and up through the larynx. This is the type that might allow a patient to speak. It's often used when they're being weaned off.
And then we have the cuffed tubes. This is the high security setup.
Precisely. Cuffed trachs are an absolute necessity if a ventilator is delivering positive pressure air. The cuff is an inflatable balloon at the tip that forms an airtight seal inside the trachea.
So every breath from the ventilator goes into the lungs.
Exactly. Nothing escapes back up.
But,
and this is a huge but, the very thing that makes it so effective is also its biggest point of danger.
how so?
Two big consequences. First, fluid can collect above that cuff, which is a big infection risk. And second, the pressure of that cuff is critical. The source stresses it must be maintained in the safe zone, which it has to be rigorously held below 25 centimeters of water pressure.
25. That seems like a very specific and kind of small number. What happens if you go over that?
If the pressure is too high, it pinches the delicate lining of the trachea. It cuts off blood flow to that tissue. That leads to ischemia, which is tissue death, and then necrosis. And that can cause horrible long-term problems. This is why managing that cuff pressure is, well, it's an obsession in critical care.
That makes the simple act of inflating a balloon feel incredibly high stakes. Okay, what about the last type, the fenestrated trach?
A fenestrated tube is for rehab and weaning. It has a little hole in it, a fenestration. When the cuff is down, that hole lets air pass up through the vocal cords, which helps with speaking.
What's the trade-off?
The trade-off is that it increases the patient's work of breathing, so it's a very careful balance.
Okay, let's pivot from the mechanics to the dangers. The spectrum of complications here is just huge. Let's start with the immediate problems, the things a patient feels right away.
Well, beyond the obvious discomfort, just the feeling of the tube being tugged on, the number one immediate danger is obstruction. Dried, thick secretions can just block the trach completely, and that's an immediate crisis.
A life-threatening crisis.
Instantly. And we already touched on cuff overinflation, but let's look at the early complications right after the surgery.
What are the big risks in those first few hours or days?
So, right after the procedure, you're looking for bleeding, you're looking for aspiration, but there are two really dangerous pulmonary complications. First is a pneumothorax, a collapsed lung, if there was damage during the surgery.
Okay, and the second one you mentioned, subcutaneous or mediastinal emphysema. That sounds terrifying. What is that?
It is alarming to see. It's when air escapes from the airway system, and because it's looking for the path of least resistance, it travels up the neck and gets trapped right under the skin.
So what would you notice? What does it look like or feel like?
If you press on the skin around their neck or chest, it feels spongy, crackly. The classic description is like pressing on Rice Krispies. That crackling is the trapped air. While it's not always life-threatening on its own, it is a huge red flag that there's an air leak somewhere in the system.
Okay, so let's talk long-term. The insidious risks from having this foreign body in your airway for months.
Yeah, these are the ones that keep clinicians vigilant. You see chronic infection, difficulty swallowing dysphagia, and the development of a tracheoesophageal fistula.
Which is?
An abnormal tunnel that forms between the trachea and the esophagus, usually from that chronic cuff pressure we talked about. It causes necrosis and just erodes a hole between the two.
But the sources point to one complication as the absolute worst-case scenario, the innominate artery rupture.
This is the ultimate catastrophe. The innominate artery is a major vessel. It's the first branch off the arch of the aorta. It supplies blood to the whole right side of your head and your arm.
And it's near the trachea.
In some people, it sits right next to it. And the trach tube, or its cuff, can slowly, over time, erode the wall of that artery.
And if it breaks through?
It's a massive, immediate, and usually fatal hemorrhage. It is an all-hands-on-deck emergency that requires extreme measures just to try and control it. It really underscores why that 25 centimeter ASHO O limit is so sacred.
The intensity of those risks really hammers home why the daily care routine is the patient's lifeline. This is not a set-it-and-forget-it device.
Not at all. The routine is all about maintaining a healthy, sterile, and moist environment inside the trachea. That means warm humidity to keep secretions from drying out and keeping the patient well hydrated.
And constant monitoring.
Constant. You're watching for infection white blood cell counts, temperature, you're watching oxygen saturation.
What about the site itself, the physical care?
That's the core of the 12-hour cycle. Every 12 hours, the inner cannula has to be changed, the dressing around the stoma has to be changed, and the track ties have to be changed or adjusted.
Every 12 hours.
Without fail.
And there was a very specific detail in the notes about those ties.
Yes. They have to be secure, but not too tight. The rule is you tighten them only enough to allow 2 fingers to fit comfortably underneath. It's a small detail, but it's critical.
Okay, let's get into the most high-stakes procedure of all, suctioning. This is what saves the patient when they're struggling, but it's also inherently dangerous.
It is. The very procedure that clears the airway is also dangerous because you're temporarily taking away their oxygen supply. The biggest hazard is hypoxia. You are literally sucking the air out of their lungs along with the secretions.
Which has to cause incredible anxiety.
Huge anxiety. And there's a risk of trauma to the airway, which can cause bleeding. Plus, there's a very clear instruction in the source material. Do not lavage.
Right, explain that.
You don't squirt saline down the tube to loosen things up. It was an old practice, but we now know it just increases the infection risk by pushing bacteria deeper into the lungs.
Okay, so walk me through the critical sequence. What's the prep?
First, the absolute rule is a suction first, then track care. Always clear the airway first. The essential prep step is pre-oxygenation.
So you turn up the oxygen.
You turn the oxygen way up, maybe to 15 liters, for a short time before you start. You're building up an oxygen reserve in their body to protect them against the hypoxia that you know is coming.
That's fascinating. You're filling the tank before you open the valve.
Yeah.
So what about the technique? The numbers?
You set the suction pressure between a moderate 80 and 120. Then you insert the catheter with no suction applied. That's vital.
To prevent damage on the way in.
Right. You insert it about 4 inches until you feel just a little resistance. No deep suctioning.
And then comes the ultimate constraint, the time limit.
Yes. Once you apply suction and you start pulling the catheter out, the whole thing should be longer than 10 seconds.
10 seconds, that's absolute.
That rule is absolute. Going beyond that dramatically increases the risk of severe hypoxia and all the cardiac problems that come with it.
That 10-second window is an incredible amount of pressure. It forces you to be precise and fast.
It does. You have to be quick, be efficient, and know you can always repeat the process after you let the patient recover. After those 10 seconds, you rinse the catheter, you reassess, and you turn the O2 back down.
And just briefly, what if there's no track?
Then you might use nasotracheal suctioning a catheter through the nose. Or for just cleaning the mouth, you use that rigid, curved device called a Yankauer.
Okay, let's run through a couple of practical scenarios. First one, eating. Can a patient with a cuffed track eat?
Yes, they can, but it's a very controlled process. You assess their swallow, and if they have a cuffed tube, that cuff has to be deflated so they can swallow naturally. But the timing of everything is critical.
How so?
You must suction the patient before they eat.
Before. Why not after, in case they choke?
Because if you suction them after they've eaten, the stimulation from the catheter can trigger a huge coughing fit or even vomiting, and that puts them at an extreme risk of aspirating food right into their lungs. So you clear the way first, then they eat.
Timing is everything. Okay, what about that cuff deflation? If you deflate it so they can eat, isn't it alarming when air suddenly rushes past it?
No, that's actually what you want to happen. When it's deflated, air can move past it, up through the nose and mouth. It's actually part of the process of weaning them back to breathing on their own.
Right. It's the pressure while it's inflated that's the danger zone.
Exactly.
Okay, final scenario, and the most immediate one. A patient with a trach suddenly can't breathe. They're in severe distress. What is the one thing you suspect?
A mucus plug. A solid blockage.
And the immediate life-saving response.
Suction ASAP. There's no time for diagnostics. The only thing that's going to save that patient is getting that blockage out within seconds.
We have covered a remarkable amount of ground today, from the reasons a track is needed to the detailed anatomy and then that meticulous life-sustaining care, especially that intense 10-second limit on suctioning.
It really highlights how so much of high-stakes medical care comes down to these subtle parameters, doesn't it? It's the difference between 25 and 30 centimeters of pressure, or sticking to that 10-second rule. These seemingly small things have profound immediate implications for a patient's survival.
It really does. And, in our discussion of long-term complications, we talked a lot about the dangers of the tube while it's emplaced in the necrosis, fistula, that artery rupture. But the source material also mentions something called tracheal stenosis, a narrowing of the airway that happens after the tube is successfully removed. And that raises a really interesting final question for you to think about.
Okay.
Even after a patient successfully navigates that whole crisis, after they no longer need the artificial airway, what happens next? How does the permanent scarring and narrowing of their own trachea impact their quality of life for all the years that follow?